our afternoon lunch talk here. Would just like to acknowledge our sponsor here, which is Davis Hospital and Medical Center, have sponsored this talk. We've heard this morning already from John Barry, and we get to hear from him again this afternoon about the Great Influenza, which is a book he wrote about the influenza epidemic of 1918. I first became aware of this book from a patient of mine, a friend of mine, who came to my house and said, you got to read this book. And in the opening page, there was a few things that really struck me about the magnitude of what happened in 1918 that I had no clue. The influenza epidemic of 1918 killed as many as 100 million people worldwide. It killed more in 24 weeks than AIDS did in 24 years. And it killed more in a year than the Black Death of the Middle Ages killed in a century. In the course of the book, he chronicles not only the disease, but also the scientists involved in the race for a cure. And then also the politicians involved, such as President Wilson. So John Barry is a prize-winning author, New York Times bestseller. He's written several books and won more than 20 awards. In 2005, the National Academy of Sciences named The Great Influenza the year's outstanding book on science and medicine. And the Center for Biodefense and Emerging Pathogens gave Barry its 2005 September 11th award. He sits on the advisory boards for MIT, Johns Hopkins, as well as federal government's Infectious Disease Board of Experts. He's advised federal, state, and World Health Organization officials on influenza. He's written for the New York Times, the Washington Post, Fortune magazine, Time magazine, and lectured at Harvard as well as the National War College. And he's been a frequent guest on Meet the Press and NPR. And currently lives in New Orleans. So if everyone could join me in welcoming John Barry.
First, I want to thank you very much for inviting me. And as I said earlier, this speech was scheduled as far in advance as anything I've ever scheduled. It was at least 18 months, and I think longer. So I think I congratulate you on your brilliant foresight, and right at hitting the cusp of the headlines. I think some newspapers and magazines need your editors to. Anyway, I was originally, of course, going to talk primarily about 1918 and what lessons it holds for us. Of course, in the last few days, I've torn up that speech, and that will still be. I'll still talk about that, but obviously the context has changed, and I have been involved for the last 5 years pretty actively in pandemic preparedness work, and have consulted in the last few weeks on a regular basis with a lot of people who are involved. And I don't have to tell you, there's a lot that's going on. The first thing I want to tell you about is the virus itself. It's an RNA virus. It's one of the fastest mutating viruses in existence. It's a virus that virologists refer to, and not Stephen King. The virologists use the phrase a mutant swarm to describe influenza and other viruses that are similar to it. It has an extraordinary mutation rate. When a single virus infects a single cell, generally speaking, 8 hours later, that single cell will produce between 100,000 and 1 million virus particles. And I say virus particles because it mutates so rapidly that 99% of those particles can't function. They cannot infect another cell. But that still leaves between 1,000 and 10,000 viruses, that 1%, that are capable of infecting another cell. And every one of those viruses is a little bit different. They're all like snowflakes. Every one is different. That's why they refer to it as a mutant swarm. And so you can see it's sort of that every possible permutation of that virus is going to be produced. And so I should have said earlier, all influenza viruses are bird viruses. There's no such thing as a naturally occurring human influenza virus. But this mutation rate allows the virus to jump species, either directly by mutation, because sooner or later one of those permutations capable of infecting another species is going to come into contact with a member of that species. Once it initially makes such contact, and far back, and it infects basically all mammals, among others, from seals to elephants. Another way it can jump species, it's unusual because its genes it's got a segmented genome. All the genes are separate. It's not a continuous strand of RNA. So what happens is if two different viruses infect the same cell, they can swap genes just as if you have two decks of playing cards. You shuffle the two decks together and then you count out a new deck. And so the new deck will include genes from both viruses. That's a reassortant virus. 1918 almost certainly entered the human population as a whole virus, most likely directly from birds. As far back as we can look in history, there have been influenza pandemics. We know about 4 of them in some detail: 1889, 1918, 57 and 68. 57 and 68, and also this one, H1N1, they're all reassortants. They're combinations of existing human viruses with some other animal genes. They refer to pigs as a mixing vessel because they have receptors that are perfectly attuned to both avian viruses and human viruses. It's unusual for an avian virus to directly infect a person. In fact, until H5N1 surfaced, the so-called bird flu, in 97, a lot of people argued it was impossible for an avian virus to directly infect people, but obviously even now we know that's not the case. So that's the background on the virus itself. 1918 was a violent pandemic. It was the most virulent influenza that we know about in history, although there actually have been some other ones that we've heard about, don't know much about, that were pretty virulent. The death toll, the lowest estimate from the death toll, you used to read more than 20 million died. I know where that estimate came from. It was 21.7 million in a study funded by the AMA that was published in 1927. They extrapolated the case mortality rate from what they knew in the West and applied it to the rest of the world. That's where that number came from. Subsequently, they realized that the developing world had much higher case mortality, probably because they were virgin populations. In some parts of the world, 20 to 30% of the entire population died. And since then, the mortality number for that has gone up. The number I use is a minimum of 50 million, max of 100 million. That number came from McFarland Burnett, a Nobel laureate who spent most of his life studying influenza. I don't know of a credible estimate today that puts the number at less than 35 million. The world population then was only 28% of today, so what you're looking at is the mortality was ranged from roughly 2% of the entire population of the world to over 5% of the entire population. As you probably know, 1918 was particularly good at killing healthy young adults. And the percentage of the population of healthy young adults would have been higher than the numbers I just said. You've also probably heard or read case mortality from 1918 was generally 2%, obviously that doesn't comport with the numbers I just quoted. What that case mortality of roughly 2% really applies to is the developed world, where people obviously did have some cross-protection from other influenza viruses that they had seen. But even in the West, there are large subgroups that had a much higher case mortality. For example, the Metropolitan Life Insurance Company, which obviously had very good numbers, discovered that 3.26% of the entire population of industrial workers which it insured died. So the case mortality in that subgroup would have been somewhere, depending on morbidity, between 8 and 13%. So it's not great reassurance, even if you think in terms of 2%. That may have been an accurate estimate for the average case mortality in the developed world, but there is still, I mean, there's no such thing as a useful average case mortality for 1918. Fortunately, H1N1 doesn't look anything like that. But I want to put a human face on what I've just been talking about. I want to read to you a letter that a physician at Camp Devens, which was in 1918, also came in waves, a quite mild first wave. In fact, you might all, if you're interested, I wrote an op-ed in the New York Times a couple of weeks ago to put this pandemic in perspective, which is obviously available to you all online. And this mild first wave, I'll give you a sense of how mild. The British Grand Fleet, which patrolled the coast of Europe, had 10,313 cases in the first wave, 4 deaths. You admit 10,000 people to the hospital today, and the hospital will kill more than 4 of them. So that's a pretty mild virus. But the second wave, which first surfaced in Switzerland in late July, was so intensely different that U.S. military intelligence was sending reports back to Washington that they're calling this influenza, but it's actually the Black Plague. And Camp Devens, just outside Boston, was the first place hit in the U.S., and this is a letter that a physician there wrote to a colleague. These men start with what appears to be an ordinary attack of La Grippe or influenza, but when brought to the hospital, they very rapidly develop the most vicious type of pneumonia that has ever been seen. Soon you see the cyanosis extending from their ears and spreading all over the face until it is hard to distinguish the colored men from the white. It is only a matter of a few hours then until death comes. It is horrible. One can stand it to see 1, 2, or 20 men die, but to see these poor devils dropping like flies. We've been averaging about 100 deaths per day. Pneumonia means in about all cases death. It takes special trains to carry away the dead. For several days there were no coffins, and the bodies piled up something fierce. It beats any sight they ever had in France after a battle. Goodbye, old pal. God be with you until we meet again. Now, and it's nice to talk to an audience where I don't have to tell them what cyanosis means, but many physicians reported cyanosis so intense that in the entire rest of their medical practice, going half a century, they never saw cyanosis like this. It obviously spread rumors for Black Plague if a physician couldn't tell an African American from a white soldier. That was an extreme example, quite typical of military bases. It was certainly better than that in the civilian population, but it was bad enough that there was plenty of terror spread. The symptoms were unusual for influenza, the usual standard set of symptoms, but in addition, they were the intestinal and other symptoms, such as we're seeing today with H1N1. It was initially misdiagnosed as cholera, as dengue, as typhoid. to give you a sense what the symptoms were like. And although those who know much about the pandemic understand, and as I said earlier, more than half the deaths were in healthy young adults, and 99% of the excess deaths were people under age 65, which is extraordinary for influenza. The speculation, of course, is at some point people of that age group had been exposed to a similar virus. Nonetheless, it wasn't like healthy young adults were the only people who died. And there is some work that was done to give you the comparison of kind of impact this had on society and what a virulent virus could have today. Richard Hatchett and Carter Mercer, both of whom are now in the White House and working on this issue, did a study comparing some other mortality figures, and they discovered that children aged 1 to 4, if today the mortality was the same as it was in 1918 for children aged 1 to 4, that would equal all-cause mortality for that age group over a period of 20 years. And for the age group 5 to 14, it would equal all-cause mortality for a period of at least 10 years. Now, in 1918, people were a little bit, it wasn't that unusual to lose a child. But today, if a kid doesn't drown or get run over by a car, by and large, they survive, at least in the West. So that kind of impact, however, of a virulent virus on a society today, we're not used to losing children. And that would be the kind of devastating blow that it's hard to figure out just what impact that would have on a society, but it would be a pretty significant one, I think. As I said earlier, pandemics go as far back in history as we can look. 1918 was not the only lethal one. In 1580, according to one account, quote, some Spanish cities were nearly entirely depopulated by the disease, unquote. In 1698, when it took at least 6 weeks to cross the ocean, a pandemic made it from Europe to North America. In Virginia, one report said, quote, the people died as in a plague. In Massachusetts, Cotton Mather, who is better known for his role in the witchcraft trials in Salem, wrote, all conditions of persons were attacked. The sickness extended to almost all families. Few or none escaped, and many died, especially in Boston, and some died in a strange or unusual manner. In some families, all were sick together. Obviously, we're advanced a lot since 1698, or 1580. But as good as modern medicine is, the chief determinant of what happens in a pandemic is still the virus itself. And it's going to be the chief determinant until we get a vaccine that works against conserved portions of the virus, that will work against any influenza virus. Medical care, even in a mild pandemic, is going to be utterly overwhelmed. For example, there are only 105,000 respirators in the United States. At any given moment, 85,000 of them are in use. Most of the rest are being repaired. So when you get an influx of cases, when I was on my book tour, by coincidence, I'm in Kansas City, a seasonal influenza outbreak. Every emergency room in Kansas City was shut down. I'm sure you're familiar with similar things happening here. And in Katrina, power went out in Charity Hospital. They were using manual respirators for days. I know what it's like to use a manual respirator. I've seen that in action. That is a pretty labor-intensive job. And one thing you're not going to have in a pandemic, even a mild one, because the morbidity is going to be about the same, you're not going to have people. There are going to be major labor shortages. So, that whole system of healthcare certainly is going to be dramatically impacted. Doctors and nurses out, supply chains interrupted, things like that. And the CDC in 1999 did a study of what would happen if there were another pandemic, mild, and concluded that, and obviously factoring in vaccines, although they ran several scenarios depending on how rapidly and how widely administered the vaccine was, and their projections were mortality in the U.S. for a mild virus ranging from 89,000 to 207,000. So I don't think anyone in the U.S. would consider that a mild pandemic today. The economic disruption, and one of the reasons for the high mortality, higher than past relatively mild pandemics like 1957 and 1968, is because demographics has changed. We have a lot more elderly, of course. That's the most obvious demographic change. We've got HIV-infected population. You have a lot of cancer survivors, which you didn't have in 1957 or even 68, who had chemo or radiation. You know, both of them damaged the immune system. So you have a lot more people with weakened immune systems walking around today who didn't used to exist. And I wouldn't be surprised if there aren't a transplant recipient in this audience. As your physicians, you realize there are actually a lot of transplant recipients walking around. And certainly a lot of people taking immunosuppressive drugs. All of them increasingly vulnerable to something like influenza. But the economic disruption from even a mild virus would also be vastly greater than it used to be, even in 1968, because the society is so much more efficient today. Everybody has a just-in-time inventory system, and basically every well-run business in the country, or the West for that matter. And, you know, where are all your surgical gloves and syringes and so forth coming from? Most of them from China. The Center for Infectious Disease Research and Policy at the University of Minnesota did a study of the drugs that you actually have to have in a hospital on various, I think, 19 different services. I've forgotten the exact number. And they discovered that virtually 100% of those absolutely necessary drugs were generic, and 95% of them came from either China or India. So with air traffic controllers out, truck drivers sick, and stuff like that, I mean, the whole supply chain issue is a very real one, and interfering directly with what you do, and also with all other businesses, not just healthcare. Every business is in the same boat in terms of supply chains. For example, to use a rather grim number, in 1968, it took 5.5 months between the time a coffin was manufactured and the time it was used. Today, it's 3 weeks. So, but again, it's every business. That's just a fairly dramatic example. The efficiency of this economic engine that we have developed is tremendous. But that very efficiency makes it vulnerable to disruption. And, you know, one of the other problems that you'll face directly, how are you going to keep patients out of emergency rooms and out of your offices if they've got influenza? You don't want them coming there and infecting all the other people. And it raises all sorts of ethical questions that and management questions and how best to handle an influx of patients. But I'll leave that to you all to figure out, or rather than pontificate. I did spend 10 years as a Washington journalist, which actually means I feel free to pontificate on anything, whether I know anything about it or not. But I try to limit that for the moment. Okay. Where are we here? So what are the actual lessons from 1918? And I think there are quite a few. And that's how I became involved in the preparedness effort, is as your former governor, Mike Leavitt, really I think deserves a lot of credit under him, there was a real effort to look at this for lessons and start what they call non-pharmaceutical interventions. What do you do when you don't have any drugs? What do you do before you get a vaccine that's widely available? And that meant looking back at history, seeing what various cities did in 1918, trying to analyze whether there actually were any best practices. And there are some. I think the most important one is actually how the government communicates. In my opinion, second only to a vaccine, the communication strategy is the most important thing in a pandemic. And I put it pretty simply. People talk about risk communication, and I really don't like that term. Risk communications implies a management of the truth. I don't think you manage the truth. I think you tell the truth. And I think that's really an essential factor in retaining your credibility. If people think that you're withholding information, that's almost as bad and maybe even worse than if they think you're lying to them. So I think it's very important to maintain credibility by telling all of the truth that you know and staying ahead of the curve, ahead of the rumors on the internet and ahead of the rumors on Twitter, and being very explicit. They didn't do this in 1918. In 1918, Wilson never made a single statement whatsoever about the influenza pandemic, ever. And they left it to lesser officials, and the Surgeon General of the United States said, quote, "There is no cause for alarm if proper precautions are observed," unquote. And another national public health official said, it was called Spanish influenza, and he said, which there are a lot of theories about where it started. I have my own but there are others. But one thing we do know is it didn't start in Spain. However, it's called Spanish influenza, and this other national public health official said, this is ordinary influenza by another name. Now, people are hearing, and this is echoed almost unanimously by local government officials and local public health officials. And yet people are seeing their neighbor or spouse die sometimes less than 24 hours after the first symptom, sometimes with horrific symptoms, the cyanosis I already mentioned, but even more frightening, people could bleed not only from their nose and mouth, but from their eyes and ears. And when people are living through these symptoms, and they are hearing this is ordinary influenza by another name, and you have nothing to worry about if proper precautions are followed, they pretty quickly lose trust in those authority figures and pay them absolutely no attention. And personally, I think that society is based on trust. And once that evaporates, society begins to fall apart. And in many places, that became pretty close to happening in 1918 in the United States. To the extent that people were starving to death because their neighbors and even their families were too afraid to bring them food. And I noticed this happening in a couple of big cities, reports of this happening. So I was curious whether that was also the case in a rural community where family, community, neighbors really supposedly meant something, because, maybe in the big city, people moving in, and maybe they're alienated anyway. But I discovered the same things were being reported in rural communities. And the fear was such that in Philadelphia, which was one of the hardest hit cities, there was, there were emergency hospitals set up everywhere, and there was I quoted a guy named Isaac Starr, who later became a very well-known cardiologist, who's then a medical student in charge of an emergency hospital. And he lived 12 miles from this hospital. And he drove his car home every day. And he started seeing so few cars on the road, he counted them. And in one day, in a drive of 12 miles, in a city of almost 2 million people, he did not see a single other car on the road. And he said the life of the city is almost stopped. And in the book has a photograph of Manhattan, where there are a couple of sanitation workers with the usual mask regalia. It's a very undramatic photo until you stop to think about it. This is Manhattan. There are cars parked on the street, by the curb, but there's not a single car on the street, and there's not a single pedestrian on the sidewalk in Manhattan. That's how much fear there was in the community. To the extent that Victor Vaughn, who was a very serious and sober guy, he had been before the war for years dean of the University of Michigan Medical School, and during the war he became head of the Division of Communicable Diseases for the Army. He said, if this continues for a few more weeks, civilization could easily disappear from the face of the earth. That's the kind of impact that this thing had in 1918. And I think that was a direct, I can't prove it, of course, but I think it was a direct, almost measurable result of lying by people in authority. And I sort of do have a little bit of a control to compare that to. And there were a couple of places, not many, but there were a few that did tell the truth. For example, in San Francisco, there was a big full page in the newspaper with huge type, a statement signed by the mayor, the members of the city council, the head of the unions, the heads of the business organizations, and big type says, wear a mask and save your life. Now, the mask didn't do a damn bit of good, but wear a mask and save your life is a very different message than this is ordinary influenza by a different name. And San Francisco did function. People didn't starve to death in San Francisco because everyone was afraid. When you're told the truth, you know what you're facing, a lot of people will stand up and act heroically, as people in your profession did. There are very few reports of doctors and nurses who fled or who didn't go forward and risk their lives. And even in Philadelphia, which was called at the time the most corrupt city in America, and whose mayor, I mean, we're talking about serious corruption. In the middle of the pandemic, the mayor was arrested as accessory to murder because of the death of a political opponent. And the police force there was not much more than a group of uniformed thugs. Cops had actually done the murder. Nonetheless, when they were asked even though the Philadelphia newspapers weren't printing the truth, and talk about reductio ad absurdum, when the health commissioner there finally closed all schools, banned all public meetings, closed churches, closed saloons, closed theaters, when that finally happened, one of the newspapers actually said, this is not a public health measure. I don't know what it was if it wasn't a public health measure, but, they never abandoned the line of reassurance that everything is okay. But the police knew the truth. And when the police were asked for 4 volunteers to remove bodies from homes, 118 cops responded. Now, that's heroism. And that's because they knew what they were facing and what had to be done. So, as I say, I strongly think that the communications policy is absolutely essential. There are a lot of other things that are sort of lessons. And also back to the communication, let me finish that thought before I go into some of the other things. It's not just communication from people in authority to the public. It's also a kind of a horizontal communication between, say, the private sector and health communities. Every major business by now should have developed a continuity plan for a pandemic. Because of H5N1, people have been thinking about it for a long time. I read in today's paper about the counties here and their pandemic plan. I'm sure the state has a good one, given Mike Leavitt's influence. But one of the gaps that I know of has occurred around the country is people making these plans haven't been talking to each other. And what may work for one business may conflict with another business's plan, much less the public health official's plan. Or a really good example that I know for a fact is occurring, that a lot of these plans are assuming voluntary organizations are going to fill gaps in X, Y, Z spots. But they're not talking to these voluntary organizations. And they don't realize that a lot of volunteers volunteer for more than one organization, so people are being double counted and triple counted in some cases in terms of the labor resources in these voluntary. So the communications to get things right for this, and I was talking about silos earlier regarding the Corps, and somebody asked me about that, and this is a good example of silos. You know, now's the time to fix that and make sure those things aren't occurring. So that's the end of my thoughts on communication, unless you want to ask me about it. But in terms of the other lessons, sort of epidemiological conclusions that have been reached by studying what cities did, even in 1918, they actually conducted some very good experiments on masks and discovered that masks work very, very well when you put them on a sick person. And I think people in infectious diseases have been aware of this for a long time. There's been work in the last 10 or 12 years in Japan that if you're sick and you wear a mask, I'm not talking about an N95, because who's going to wear an N95 mask when you're sick? I mean, it's almost impossible. It's hard enough when you're well to do it for 15 minutes. And I referred in the other talk about the people working in mold houses. Even the professionals weren't doing it right in New Orleans. But just a surgical mask on somebody who's sick is a significant protector of people who are well. If someone is in your home and sick, if you isolate that person as much as possible from the other members of the family, and if somehow you can put a mask on that person, which is not that easy for a sick person, how many parents are going to put a mask on a sick child? It's not comfortable. But that will protect the other people in the family. You know, it's not an absolute guarantee, but it's real protection. Social distancing measures, they're self-explanatory. You know, there are a lot of models that suggest that these will work. The MIT people whom I work with, they're modelers. I sort of provide them with reality testing on some of their assumptions. The CDC's done a lot of work on this stuff. I think, frankly, unfortunately, a lot of the CDC modeling is based not only on soft data, but on absolutely factually incorrect data. But that doesn't mean the conclusions are wrong. The one, you're going to hear about stay home, telecommute, and so forth. I think these things will flatten out the peak of the curve. However, they're not. The virus is going to find you. You're going to be exposed, and people need to understand that. The other thing is, on telecommuting, for example, there's no capacity to handle the kind of influx in traffic. So that's not a solution either. It's not a perfect solution. However, spreading people out and so forth, it will slow down the curve. The one probably dispute that I have with CDC, and I'm not isolated in this, although I'm in the minority, one of the people I stand with on this is Donald Henderson. I don't know if you know him, but he's was in charge of the WHO program to eradicate smallpox, and he's also one of the pioneers of the anti-bioterrorism effort. He and I and a few others are sort of in the minority. We're not convinced on school closing, partly because to actually work, you got to keep the kids from going to the mall, and you've got to keep the kids from playing basketball, and you've got to sustain that effort for a long period, for a number of weeks. So when you factor that in with the burden on society, I'm not sure the school closing is the best. There's also some data from past pandemics that suggests school closing is not really the route through which the virus travels. In 1957, I think the data is quite clear that the schools did lead the way in passing the virus. But there's data from 1889, 1918, 1920, several studies, which are good, hard data, where in all there are like 5 studies, and all of them, the first case in the household, ranging from 80 to 90% in 5 different studies by different people, were adults. If the first case in the household is adults, then why are you closing the schools to stop the spread of the disease? Now, there may be a difference between a reassortant virus, which we're facing now, or seasonal influenza, where it also looks like it spreads in schools, and 1918 and 1920. And the difference is the immune naivety. You know, in 1918, nobody's immune system in the world had ever seen the virus before. In 1920, everybody had already seen the virus, at least if they were old enough to be going to school. So there, the immune systems between adults and children were identical in terms of whether or not they'd been exposed to the virus. But in seasonal influenza, as well as in 57 and 68, when they were reassortant viruses, the adult population had seen that, something akin to that virus before. Children had not. So there may actually be some way of bringing this data together. That's pure speculation, and I'm not an epidemiologist, and I've actually, a couple of weeks ago, prior to H1N1's appearance, I've just shipped this data off to a collaborator of mine that I've worked with in the past at NIH, an epidemiologist, to translate this stuff into mathematics and science speak. One other thing I didn't mention that's important, in 1918 there was clearly established without a doubt that the first wave provided protection against the second wave. And I did something for JID, which ran last November, which I think is pretty compelling, and you can all find that if you're interested. Finally, where do we stand now with H1N1? What do I think is going to happen? I think it is a serious threat. It's a real virus. There's a precursor others have tracked back to 1998. There is a human infection tracked back to 2005 in North Carolina. And it looks like right now the virus, to me, seems as it is not yet an efficient invader of humans. Clearly, it goes human to human to human to human. But epidemiologists talk about the R0, the reproductive number. How many cases are generated by the index case? And seasonal influenza has an R0 of roughly 1.8 to 2. So that one person sick with influenza generally creates close to 2 other cases of people with influenza until it spreads through a community in 6 to 8 weeks, burns itself out, and then you're done with it. But work on this, the modelers I work with at MIT, I was just emailing them before I came on, they think the R0 is only 1.2 right now. There was a piece published in the last couple of days in Science that estimates the R0 at around 1.6, which is still significantly less than seasonal influenza. So what that suggests to me is that this virus most likely is going to get better at infecting people. And there's also work that suggests, that concluded, at least in this paper, that the R0 for 1918 ranged from 2.4 to 4. If that's true, then all the models are just, might as well throw them out if it's that high. But I think it's quite reasonable to think that 1918 had a reproductive number higher than seasonal influenza. Right now, H1N1 is lower than seasonal influenza. I think most virologists will tell you this virus will continue to adapt to humans. We'll get at least to the level of seasonal influenza in terms of its ability to infect, whether it comes back in September, October, November, December, or whether it takes 2 years or 3 or 4 years, this virus is going to be back. And right now, actually, it looks a lot like the 1957 virus. One of the people whom I mentioned a minute ago, D.A. Henderson, the smallpox guy, actually was a young epidemiologist at CDC, or I guess CDC's precursor, Center for whatever it was called back then. And that was his first exposure, and I was just reading an article that he wrote, I think it was in JAMA, but you can probably find it if you're interested in the 1957 virus. I know that his gut is that it's like 57. 57, according to another JAMA paper that I was just reading yesterday that came out, and there were actually 3 waves. First wave in the fall of 57, a second wave January to March 58, a third wave in January to March 1960. Total mortality, excess mortality of 86,000 in the United States in a population half the size of today's. And of course, as I said at the beginning, the demographics have changed more. We have a much more vulnerable population. So anyone who thinks that H1N1 has been overblown, think again. So on that cheerful note, well, I'll end on a cheerful note. I went to the Sugar Bowl, and I was very happy to see Utah trounce Alabama. So happy to take as questions until they tell me to leave the stage. Yes. Well, I'm not, number one, we've only had, that wasn't the case in 1957. In 57, the first wave killed 36,000. The second wave killed 20,000. The third wave killed 27,000 in the U.S. 1918, the second wave was much more virulent, infinitely more virulent. The hypothesis would, the 1918 first wave, while widespread, was not even like seasonal influenza. It sputtered across countries. High infectious rate in army camps, but relatively little spillover into civilian communities. It wasn't really great at infecting people. And when a virus took over that happened to be very good at infecting people and spread all over the world very rapidly, long before airplanes, that happened to be a virulent virus. There was also a third wave in 1919. You could consider a fourth wave in 1920, which was actually, except for 1919 and 1918, the third worst, the worst year in the 20th century. So it just wasn't great at infecting people, and by coincidence, the one that kicked into people and was efficient was pretty virulent. Then partly the virus mutated toward mildness, and if you didn't know, that original virus was H1N1 also, but that just makes this one sound scary. There's totally different issues. And partly people's immune systems had seen it before. Incidentally, in the avian population, the viruses are stable. They're very unstable in humans because, it's a new species. It's new to the virus. But over, a long, long period of generations in birds, the virus is stabilized. H5N1 was different. H5N1 was not stable even in birds, nor is it, plus it's lethal. There are a lot of bird viruses that are not lethal to birds. So the speculation would be, and also in 1889 to 1891, the third wave was the most lethal. It got increasingly more dangerous. 1968 was kind of interesting. In 1968, 70% of the mortality in was in the first wave in the United States. There was a second wave, which was considerably milder in the United States. But in Europe, the second wave had 70% of the mortality, and only 30% in the first wave. You know, exactly what's going on in 68, I mean, influenza it's a very volatile, unstable virus when it enters the human population. It's just hard to predict. As a friend of mine said, he knows a lot less about influenza today than he did 10 years ago. So, yes. The question was, do I think it's safe to travel to Mexico? You know, I used to joke with my wife, and more than once said it publicly in a speech like this, that if a new pandemic surfaces and it looks like the first wave in 1918, I'm getting on an airplane, I'm going there. Because there was no question it was protective, at least, you know, comparable to a modern vaccine, first wave exposure in 1918. And I actually got a call from a New York Times reporter a couple of days ago that people are talking about exposing themselves, and they're quoting me. I said, well, I've actually never said that publicly or privately about this virus. And but I wouldn't be afraid of it. I'm not yet ready to get on a plane and go to Mexico because I don't really know what the virus is like yet. The early numbers, and this was published online in the last couple of days, are that the estimate is that there are probably between 20 and 30,000 cases in Mexico, with a mortality rate around 0.4, which is about 3 or 4 times seasonal influenza. One of the more interesting and yet to be understood is the deaths down there mostly are viral pneumonia, not bacterial pneumonia. Now, there have been a lot of papers out, including by some people I have great respect for, primarily Jeff Taubenberger, who's a guy who sequenced the 1918 virus. He pulled it off a preserved tissue in the Army Medical Museum and sequenced it. And I think he's a great scientist and a really serious guy, very rigorous. And he thinks that well over 90% of the deaths in 1918 were bacterial pneumonia. I frankly, as much respect as I have for him, I have a problem with that conclusion because I just don't think, from my gut feeling from all the data that I read, but I didn't methodically systematize it and try to figure out the actual epidemiology.